All right, good afternoon, everybody. Good afternoon. Good to see you guys. Good to be with you today. Just a couple reminders about what we have going on for the rest of the week. I don't think you need any reminders, but just in case. Quiz tomorrow, right? So axial bones in the lab tomorrow, okay? And then we'll have exam 2 here on Friday, okay? Make sure to bring a fully charged laptop for that exam on Friday, and then again, make sure to bring your textbook and your laptop if you or your whatever device you use to access the textbook for lab tomorrow. Make sure to have your skeleton lab handout with you tomorrow. Tomorrow will be mostly review day, so we'll do that quiz, and then it'll be your last chance to get your hands on those bones before the practical. So, okay. And Professor McGaw will go through a little bit more about exactly what the practical will look like tomorrow with you guys in lab. But any questions about anything else that's going on this week? Okay, so remember the stuff that we do today in class will be the first material on exam 3, just like how it always is on Wednesdays before an exam. Okay, so everything from the Wednesday before last exam up through last class on Monday is the stuff for exam 2. Okay. All right. So we can do this one here real quick if you want. Just if some of you came in a little bit later, that we had these kind of going, but yeah, go ahead and just with the people on your team, just see if you can identify each of these, and see if you can name a spot where you would find these, a location where you would find each of these in the body.
On the PowerPoint, it said this was fibrocartilage, but it's not, right?
It's not, no. Oh yeah, that's fibrocartilage. It is. Yeah. Yeah. Yeah, two different views of it. Go back to your notes. You'll see the two.
This looks like fibrocartilage.
Yeah, so this one, so that looks like it, and then but it also can kind of have this look too. Yeah, let me double check. What does that see? I'm pretty sure CS too. Let's double check. All right, why don't you guys on your clickers go ahead and send in one that you would find in the external ear. Yeah, that's just a more zoomed out view of fibrocartilage. What that is. Yeah, this one's more zoomed in. The other one's more zoomed out. Yeah. You can see a lot more cells. Okay. Anybody else? I got 60 responses. Anybody else? 62. You're sending in the one that you would find in the external ear. All right, I got 65. That's pretty close. See what you guys said. Good. So 95% of you are saying D. Okay. And what is D? Elastic cartilage, okay, not elastic connective tissue, but elastic cartilage, okay? All right, what's A? Fiber cartilage, okay? How about B? Dense regular. Where would we find A? One spot. The disc, intervertebral disc, for sure. Also meniscus type structures in joints as well. Where do we find B? Tendons, ligaments, okay, good. What's C? That one's fiber cartilage as well. It's a little bit different. It's just a little bit more zoomed out of a view of fiber cartilage. This one is more zoomed in. Okay, this one's more zoomed out. Okay, D, we said elastic cartilage. What about E? Dense irregular. And where's the spot we would find that? Okay, in the dermis. Okay, good. All right. Okay. So that was just a quick review for stuff for the test on Friday. Now we're going to switch gears and go into the second part of talking about the skin. Okay, the first part will be on exam 1. It was the TBL day. Now we'll talk about the kind of more of the appendages of the skin, some of the things that stick out of our skin. Okay, so talk about hair, nails, oil glands, and sweat glands. All right, and then at the end we'll get into some fun pictures of skin type injuries. Okay, so if you're yeah, now you're all going to look ahead and look it up, but it's much better in color anyway, so don't worry. But you'll see in a sec. Okay, all right, so let's talk about the hair first. So hair definitely has some functions besides just physical appearance, right? It protects us from insects, especially hair on our arms and legs. Certain insects aren't heavy enough to activate touch receptors if they just land on our skin, but if they land on that hair, it bends the hair, that can activate a touch receptor that way. So there's a little bit of function there. In animals that have a lot more hair than us, it helps with warmth, not so much with us, maybe some of us, but not all, most of us not so. Definitely hair on their head can protect against physical trauma, okay? Something hits you, it has to kind of get through the hair first, right? And a lot of times that can really protect your scalp quite a bit. Our eyelashes help us shield our eyes. Nose hair has some functions, believe it or not. It catches things, helps to filter things that are going through our nose. Okay, let's look a little bit at hair. Or do you still need to see that? We good? Okay. As far as the hair shaft goes, this is the part that we can actually see. The visible part is the shaft. Okay, that's made up of that same type of protein that we have in our skin, keratin. Okay, but there's different types of keratin and varying levels of hardness of keratin. And the one in our hair is a little bit on the harder side versus the type in our skin. And then we'll have the same thing in our nails, which is even a harder form of keratin there. Okay, so the root of the hair follicle is where we add more cells, and we're constantly adding more cells to that shaft as it's working its way up while it's in its growth phase. Okay, the texture of hair is kind of shown over here. It's driven primarily by the shape of the shaft. Okay, so if it's a nice round shape, then it's straight, and the flatter it gets, the more curly or coiled the hair gets, and that's just kind of what you see here. So the very flat type shape it creates much more coiled, very curly hair, and then everything in between there. Okay, the color is primarily dictated by how much pigment that is put into those cells as they're added when they go up as we're adding more to that shaft as it's growing. Okay, and so red hair in particular has high levels of iron in it. Okay, so the melanin, and again, these are those melanocytes, those same cells that are putting pigment into our skin cells, are putting pigment into our hair cells. And so some pigment tends to contain more iron, which makes it more red. One interesting thing about gray hair is that it's when the melanocytes aren't doing their job very well anymore. They're still doing the job of creating little vesicles of something, and then they're putting it into those cells as the shaft is growing up. But there's actually no pigment in that anymore. It's actually just little air bubbles that they're putting into the shaft instead. And so the hair is almost clear in a way when in the gray type hair. Okay. Yeah, and split ends look something kind of like this, right? It's when those keratin protein fibers are just kind of frayed on the ends. So this would be like a microscopic view of the end of a shaft. And we can see the different types of hair shape here as well. Okay, any questions on hair so far? Okay. Sometimes I'll just get peppered about hair questions and I can't always answer all of them, but I'll do my best if you have any. Okay, a couple of things about the way hair is distributed. We have two primary kind of categories of hair type, vellus hair or terminal hair. Vellus hair is kind of the very short, fine, unpigmented. Pre-puberty, this is most of our hair on our body is vellus hair. Okay. And most body hair in women post-puberty is still dominated by vellus hair, not all. Okay. And then terminal or more coarse hair, this is more hair like pubic hair, hair on our eyebrows, eyelashes, as well as the hair on our heads. And there's varying levels of it, right? Varying levels of kind of thickness and stiffness of the vellus hair or of the terminal hair. Okay. Testosterone during puberty will cause a shift for certain hair follicles go from being vellus hair follicles to terminal hair follicles in both males and females. Okay. All right, so the hair growth cycle, this is just kind of a funny little cartoon that I found that shows it pretty well. The cycle will start with the hair kind of growing nice and thick. Okay, eventually that hair root starts to degenerate a little bit. Okay, and then it's pretty much the length that it's going to get to at that point. Okay, and then after that the growth will kind of stop completely, but you'll kind of have that strand of hair just being there for a little while, and then eventually the new one comes in. This guy with his little binky there, the baby hair. He comes in, he or she comes in. It's probably more likely she. I'm just kidding. and it pushes the old hair out, so that old one falls out. But then there's this period of time where there's no hair coming out of the follicle. Right? There's one just kind of down there resting, getting ready to go. Okay. And so with eyelashes, there's growth for about 30 days, and then there's about 105 days of rest. Okay. Just for example, the scalp hair follicles on average grow for about 3 years, but then can rest for about 1 to 2 years. Okay, so lucky for us, they're not all in the same cycle, right? We have hair for a few years, then we're bald for a couple of years, right? It's not like that. Okay, they're all on different parts of the cycle at different times, right? So we kind of have this constant cycle of certain follicles have hair in them, other ones don't. Okay, with male pattern baldness, the hair follicle itself is actually lost. And there's definitely connections, genetic links to this, as well as links to testosterone levels. And then if the follicle is able to come back, it'll revert to more of that vellus type hair instead of the coarse, thick hair. It tends to be linked to your mom's dad. Is kind of the best way to try to track down if you're going to end up bald for you guys out there. look at mom's dad and see how his hair is doing. My kids are shot. My wife's dad was my wife's dad was bald when he was like 20 or something. So he was already had lost the hair up here when he was 20. So yeah, I haven't explained that to my kids yet, but it's fine, you know. But, yeah. So. Any questions about any of this? All right. So let's talk a little bit about nails. Okay. Functions of our nails. They're definitely a form of protection, right? When we're grabbing things, gripping things, even sometimes I've done this multiple times when I'm cutting something, cooking dinner, and the knife slips and I hit my thumbnail instead of my thumb. I'm like, oh man, glad I had that nail there. It didn't cut myself. Right. So we have protection that way, but they're also tools, right? We use them to squeeze things, cut things, pick things up. Definitely useful. These are the very hard type of keratin. Okay. The growth cycle in these varies a bit. Fingernails, it takes about 6 months to grow completely from no nail to a full nail. Okay, whereas toenails are much longer, about 3 times that length. So you may have noticed you have to clip your fingernails more often than you do your toenails, and they are on a different growth cycle. Sure. Okay. All right. Okay. How about oil glands? These sebaceous glands. they produce what's called sebum, which is this oily, lipid-rich type substance. And if we go back to our definition of the two different types of secretion that we talked about before, we had the holocrine and the merocrine. Which ones do you think this would be? Holocrine, right? Because cells have lots of lipids in them, right? And so when the whole cell falls into that gland and then works its way out, there's a lot of lipid in the cell membrane as well as other parts. And so the oiliness actually just comes from the cells themselves. That's really what it is. Okay, so these are holocrine type glands. Okay, the glands themselves are sensitive to testosterone. Okay, and so the more testosterone on board, the more oil they release and the more secretions they release, which is the connection, at least in males, and as far as the connection with puberty and acne formation. And yeah, all of a zit, and this is kind of the cycle of a zit down here. Okay, so what you see here is these little glands, these sebaceous oil glands, they're going to be associated with hair follicles. Okay, and so they release their secretion into the hair follicle, and if there's nothing blocking it and it's not too much secretion, it can just go up. It can just go on the surface and kind of keep your skin nice and moist. Okay, but then at some point, if we get too much secretion, like in times of high levels of testosterone release, or the skin is dirty and it's in the end of that thing is plugged up, then we get a bunch of oil secreting being released. It gets stuck in there. And there's also usually some bacteria in there too, right? Because you have bacteria in your skin. And so then we just kind of have this plugged up thing, nice little place for bacteria to grow and enjoy themselves, and turns into a zit, right? So then that white stuff is the pus from your body trying to destroy that bacteria and some of the byproducts of that. And that's what we get here. So we get that zit. Okay. Yeah, any questions on that? Okay. So we don't have these types of glands in thick skin. So places like our palms of our hands, our soles of our feet, but we do in most other places besides those areas with really thick skin. Okay. We have large ones on our face, neck, and upper chest. And yeah, acne is really just an infection of one of those little hair follicles that has a sebaceous gland attached to it. Okay. All right. So another type of gland, we have what's called the eccrine sweat glands. Okay, the eccrine sweat glands are we have lots and lots of these in our body, somewhere around 2.5 million of these. Okay, in a lot of ways, this is what sets us apart from other animals. For example, most animals like horses and antelope and gazelle and all those things, they don't have sweat glands like this. Okay, and they can't cool their bodies down when they exercise like we can, and so certain tribes in Africa have taken advantage of this. And there's a type of hunting that nomadic tribes in Africa use called subsistence hunting, which is pretty much they just slowly are chasing down animals like that for days at a time sometimes. And those animals are way faster than the humans are, but if they push them for long enough, they eventually just collapse because of heat stroke, because they can't cool their bodies down. They don't have these sweat glands. They don't have the ability to cool themselves down like we do. And so it's one of the adaptations that humans have that really sets us apart in terms of thermal regulation compared to a lot of other animals, most other animals. Okay, so what's secreted here is mostly water. Okay, definitely some salt, and then a little bit of metabolic waste. But these are definitely merocrine glands. Okay, and the function is temperature regulation. Okay, and we talked about this before. We want that water to evaporate. Right? If it just goes onto our skin and falls off, it's just a waste. It didn't help us at all. Okay, we're just wasting water if we do that. But if it goes onto our skin and then the energy from within our body warms up that water enough to turn it into vapor, then that energy came out of our body and it cooled us down a little bit, right? And that's exactly what we're trying to do with sweat. And so the more humid it is, it's harder to put more water into the air because there's already a lot of water in the air, right? And so it makes it harder to sweat. It makes it hard to sweat effectively, at least. We can still sweat, but we can't really evaporate the sweat. Okay. These are not associated with hair follicles, and we have the highest concentration in our palms, soles, forehead. We can see those here, not associated with hair follicle at all. Okay, and it's kind of interesting. You'll see that the end of the duct is actually right there in the bottom of the epidermis. So the water just kind of squeezes its way through those cells in the epidermis. It's not like the duct goes all the way to the top of the epidermis, which makes sense because those cells are constantly being turned over, right? So it wouldn't really work to you'd be losing the end of that duct constantly as the cells are being turned over. Okay, and then we have apocrine sweat glands, which this is what all those other animals have, and they don't have the eccrine ones, they just have these ones. And so it's much less, okay, only about 2,000. Most of these are in places that tend to not smell very good, okay? So your armpits, your anogenital regions, okay? Secretion mechanism here is still merocrine, okay? So definitely some sweat as far as water goes, but there's also proteins and lipids included in this secretion, some. And these are, again, are always associated with a hair follicle. Okay, they're much bigger than the eccrine sweat glands. And their function is a little bit different. They help protect us from bacteria. Okay, and the odor that we smell, these are the ones that cause BO, right? Body odor. And that's because the bacteria on our skin degrades those proteins, and the byproduct of that is acidic. And that smell of that typical smell of locker room is that smell of the acid byproducts of breaking down those proteins. And this is part of what's helping us create that acid mantle on our skin, right? Where this, because they're breaking this product down, and then that's dropping the pH a little bit. That's actually making for a less nice environment for those bacteria to thrive on our skin. Okay, any questions about any of those glands? Okay, so then we have some specialized glands as well. So these ceruminous glands they're a modified apocrine gland. They produce a very thick waxy secretion, and these are what make our earwax. Okay, so similar to those apocrine glands, but just a much thicker, waxier secretion, and we really only find them in our ear canal. Okay, and the mammary glands are really a modified version of those eccrine sweat glands, and they obviously produce milk. It's known in many circles as liquid gold. Okay, the breast milk is so there's many things that we can kind of replace by using formula. As far as nutritional needs, as far as the right amount of carbohydrate and protein and fat, we can do that pretty well with formula. The big thing that we can't do with formula is we can't reproduce the immune benefits of breast milk. Okay, for example, then this changes on a day-to-day basis. So, for example, if the mom has taken in some kind of a virus, okay, she's starting to get a cold, she's already producing antibodies against that virus. Okay, and those antibodies go directly into the breast milk, and the baby gets those antibodies to help protect it against the cold that the mom is already fighting, right? And a lot of times the baby doesn't even get the cold because mom's already helping protect it from that cold. Okay, and that literally can change on a daily basis, right? Whatever is interacting with the baby, whatever's interacting with the mom and the baby, the mom's going to be sending defenses to the baby for that. One of the cool things that researchers have looked at a little bit is it's super common during breastfeeding for the baby to reach up and stick his or her hand into mom's mouth. Okay, you guys have ever seen that? It's always really cute. It's always like grabbing. Sometimes they're like ripping her jaw off, like while they're doing it. But there's some theories to say that at least functionally, one of the functions of that, who knows, like, obviously the baby's not thinking I'm going to give you all the antigens on my hand, but functionally that's really what happens. Whatever's on that baby's skin is going to go into the mom's mouth, and then mom is going to produce an immune response against those antigens, right? And then give the baby antibodies to fight against that. So kind of a beautiful picture of how the mom is protecting the baby just right from the get-go. So yeah. Any questions on that? Okay, so we'll talk a little bit about some skin pathologies here. We'll start with skin cancer, and then we'll move into more kind of traumatic injuries to the skin. Okay, so super duper common, right? About 1 in 5 Americans develop some form of skin cancer. Okay, the vast majority of all of this is of the benign type, which just means it's a tumor, but it doesn't spread throughout the body, right? If it's malignant, then it's a tumor, and then that tumor gets into the bloodstream in some way, gets in the lymphatic system in some way, and spreads all over the body. Okay, so the vast majority of skin cancer is benign, but there definitely are some malignant types that we'll talk about. Okay, so how many in the class have had somebody, an immediate family member, that's had some kind of skin cancer dealt with, where they've had to have some part of their skin removed or those kind of things? Yeah, so more than 20% for sure. Probably half of you guys have, not you yourselves, but an immediate family member. And so yeah. So the big risk factors are things that you would assume to be true. So sun exposure, fair skin, and then just age. Age is a huge one, obviously. Okay. I'll let you finish writing that. Okay, so 3 primary types of skin cancer that we'll get into in this class, and a lot of them are named by the types of cells that that are the problem. Okay, so the first and most common type is called basal cell carcinoma. Okay, and so we find this in this layer called the stratum basal, which we don't learn the names of the layers anymore, but that's that bottom layer, that basal layer that we talked about of the epidermis, that's constantly making new cells and sending new cells up to the top of the epidermis. Okay. And it makes sense that cells that are dividing a lot are ones that might be more likely to become cancerous, because they're constantly dividing and we're having to go through that DNA replication process many, many times. And there's possibility for mistakes when that happens. Okay, so very, very low malignancy, doesn't very often metastasize, but this is 80% of all of those cases of skin cancer, and about a 99% cure rate. Okay, and this is an example of what a lesion from basal cell carcinoma might look like. Okay, and then we have, go ahead. Okay, malignancy. So back to this idea that when it's benign, it's a tumor, yeah, like it grows, but it doesn't spread all over the body. But when that tumor becomes malignant, then it's spreading all over the body too. Right? And so it's usually because it got into the bloodstream or it got in the lymphatic system in some way. And so, for example, when you're getting tested, when you have skin cancer, sometimes if it looks like it might have spread, then they'll pull a lymph node out that's close to where it was, right? And then they pull that lymph node out, and if it's all lymphatic cells in there, then we're good. Okay, there was no metastasis, at least there. But if we see a skin cell in your lymph node, then we know we're in trouble, right? Because there's not supposed to be skin cells in your lymph node. Or other types of cancer, we can find a lung cell in there, a bone cell in there, right? And that's when we know that some malignancy has happened, because it's gotten spread through the body and some of it's ended up in our lymphatic system for some reason. And so we got cells there that aren't supposed to be there. So yeah, good question. Other questions? Okay, so then we got squamous cell carcinoma. Okay, and this is another layer that, again, you didn't have to know the names of those layers, but it's called the stratum spinosum. But this is really those squamous cells, the simple, or not simple, but the stratified squamous epithelial tissue of the epithelium, and it's those keratinocytes. All right, so not the bottom layer of those keratinocytes, but somewhere up a little bit higher from that is the ones that are becoming cancerous here. Okay, this is the second most common. Definitely a high cure rate if it's caught nice and early. Okay, if this is able to stay undiagnosed for a long time, then it can become malignant. Okay, but then the worst one, malignant melanoma, and this is due to the melanocytes having problems. Okay, malignant melanoma, right? The melanin is those cells that produce melanin, the pigment, right? And the oma part is just meaning some kind of tumor, right? Okay, so about a third of these happen in moles that you already have. Okay, so that's not all of them, but very, very highly malignant. Okay, only 5% of total skin cancers are malignant melanoma, but in general, this can be fatal. Okay, and the survival rates of this have improved a lot in the past 10 years with different types of therapies. But 10, 15 years ago, it was somewhere around like a 95% fatality rate. But it's gotten a lot better with treatments as well as screenings. But this is kind of what that might look like. Okay, And this is just kind of a little infographic to give you an idea of some key things to look for to see if it might be melanoma. Okay, so one of the key things is these moles or blackish spots are asymmetrical. Okay, they don't look the same on both sides. Okay, the border integrity is another key part. The borders tend to be blurry when you have on a melanoma spot. Okay, the colors there tend to be multiple colors within the same splotch with melanoma. Okay, and then they tend to be bigger too than other ones. And so those are just kind of 4 things to look for with melanoma. Okay, any questions on those? Okay, you guys ready for some nasty pictures? Okay, all right. Okay, so we're going to talk about burns first. Burns always lots of potential for some nasty pictures. So that burn there is an electricity burn, so from a high voltage line. Okay, we'll talk about some of those in a second, but a lot of times with a high voltage burn or a burn from electricity is there's usually an entry point where there's some burning, and then there's an exit point where there's much more extreme burning a lot of times where that electricity kind of like blasts out of the body. And so, but yeah, lots of different things can cause burns, obviously fire, steam, hot things, chemicals, electricity, light, obviously, and radiation. Okay, so let's talk about the degrees of burns a little bit. So a 1st degree burn involves only that first layer of skin, only the epidermis. Okay, so we get some damage to the epidermis. Sometimes it gets all the way down to the dermis, but no damage to the dermis itself. Okay, so the skin is typically red, dry. This one definitely hurts quite a bit. Lots of pain involved in 1st degree burns. Okay, and the pain is due to the fact that there's still nerve endings intact. Right, there's still nerve endings there, so you're still experiencing all of that. Okay, there may also be swelling right in the center of the burn area, and sometimes right around it as well, and sometimes blistering too. Okay, 2nd degree burn or partial thickness burns damage both the epidermis and the dermis. Okay, so we see gotten all the way through the epidermis there, and now gotten into the dermis as well. Okay, not really getting into the underlying tissue below the dermis, but into the dermis. This one you expect to see lots of blistering happening. Okay, lots of swelling and redness occurring within 2 days. Okay, so it's not. The swelling and redness could get a lot worse over the first couple of days after the injury. Okay, and then the skin around it tends to all have 1st degree burns on it. Right? So you kind of have a spotted look around the edges of the 2nd degree burn. Okay, and this one usually induces severe pain, lots and lots of pain with 2nd degree burns. Okay, this one's pretty bad here. So full thickness burn or 3rd degree burn. This damages all layers of the skin and then also underlying tissues. Okay, so we get that hypodermis as well, which is the fat layers, can get down into the muscle as well, and even in some severe cases, even damage some of the lining of the bone as well. Okay, sometimes this is difficult to distinguish from 2nd degree burns, but a lot of times there is some level of charring to the skin, like some blackness to it, black or dry and white. Sometimes there's not really any pain at all in the injury site because the nerve endings are just gone. Right? They're just not there anymore. Okay, but there'll always be pain in the periphery of that where there's not as deep of burning, but in the deepest part itself, a lot of times they don't feel much. Okay, one of the big complications with burns is loss of body fluids. Okay, when you've had a lot, go ahead. It just depends. Yeah, there's definitely cases where it doesn't, but then other cases where it does, and yeah, so it just depends for sure. And there is some evidence of for the longest time it was always thought that nerves just don't heal. Right? If you damage a nerve, you're pretty much toast. It's not coming back, but it's not really true. There's definitely evidence of nerve regeneration, both in the brain and the periphery some. But it's, yeah, so in some cases it can come back really well. In other cases it doesn't ever come back. Yeah, it really just depends. Good question. Other questions? Okay, so there's 2 big things we're worried about with burns. Number one is their blood pressure dropping drastically low. Okay. The reason for that is because what was one of the primary functions of the dermis? It's got a lot of blood in it, right? And so if all of a sudden we just boil all of that blood, which is literally what happens, right? We just vaporize all of that blood, we've just lost a significant amount of our blood, right? And so all of a sudden our blood volume just dropped. And this is why there's these different rules about kind of gauging how much of the body is involved in a burn, because if it's a certain percentage of the body, then we're extremely concerned about the patient going into shock because they've lost so much fluid, right? So their blood volume drops pretty drastically within a matter of seconds, right? Because that water literally just vaporizes, okay? So blood pressure drops, that can be life-threatening, right? And they can go into shock. And what shock is really just low blood flow to vital organs. Okay, and it can be caused by a bunch of different things. It can be caused by a loss of blood, it can be caused by a burn because of that loss of fluid. It can be caused by your heart not pumping hard enough. It can be caused by your blood vessels opening up too much. Lots of different things. But the common thing to all kinds of shock is that you don't have enough blood flow to your organs, right? And so shock is definitely a risk of severe burns. Okay, and this is just the shock position. You could put somebody in, laying them down, elevating their legs, just using gravity to try to get that blood to go back towards their core so they can allow them to produce enough cardiac output to maintain their blood pressure. Okay, and then obviously the number 2 concern is risk of infection, right? Because our primary defense against infection is the barrier that our skin makes, right? So all of a sudden we've lost all of that, then we got a hugely open area to infection, right? So those are kind of our 2 main concerns with burns. Okay, questions about any of that? Okay, we kind of already went through this thing with the blood blister versus regular blister, so we don't need to do that again. But let's talk about some types of wounds and just kind of be able to identify these different types of wounds that we might have in the skin. Okay, so we'll look at each of these. All right, so an abrasion is really just a scrape, right? When you scrape your knee, it's some kind of blunt trauma to usually a kind of on something that's typically kind of flat, right? Where you slide on the asphalt, you slide on a dirt road, right? And it scrapes off some of the top layers of the epidermis, okay? Whereas a laceration is a clean slice, right? Nice clean slice. Lacerations can be stitched back together a lot of times with sutures, okay? But yeah, just the names of those things. Clean slice versus a scrape. Okay, puncture wound, obviously, is what it is. It's some foreign object being jammed into the body, into the skin, and staying there. An avulsion can be a term used for something we'll talk about with a bone type injury as well. We can have an avulsion fracture, where a ligament or a tendon actually rips a chunk of the bone off. But in this case, we can also have an avulsion of the skin, where just a chunk of the skin is actually ripped off in some way, and yeah, that one's pretty nasty. Okay, so we got puncture wound, avulsion. Okay, amputation is, I gave you guys a drawing on that one, so that's probably better for some of you. Some of you are disappointed. Yeah, so obviously that's some limb, some extremity, some appendage being actually removed from the body. Okay, and then contusion. Okay, contusion is just a bruise. Okay, but I say just a bruise lightly because contusions can be severe. A lot of times you'll see this, like in the NFL, you'll see this guy's out for 2 weeks with a thigh contusion. You're like, oh man, I got a thigh bruise. That's not that bad, right? But it can be extremely debilitating. Okay, so pretty much there's some kind of blunt force coming down on the externally, and then that usually squeezes all the tissues below against your bone, right? And so in some cases, it can actually tear your muscles when you have a bad enough bruise, right? If it just squeezes hard enough with enough pressure, like somebody's helmet hitting you in the thigh, right? They're both running at 15, 20 miles an hour at each other, and a helmet hits right on top of that, on top of one of those quad muscles, pinches it against the femur, right? You can tear quad muscles that way pretty easily. So contusions can be pretty bad. Okay, any questions about any of these injury types? Okay, these next 2 slides are just extra info. You won't be tested on it, but I always got questions on these, so I made some slides on it. Okay, so students would always ask what happens when you get sunburnt. Okay, and so this is a microscopic view of the skin after a sunburn. Okay, and so those UV rays actually damage the DNA in those keratinocytes, so much so that they are programmed to destroy themselves, go through apoptosis. Okay, so if there's enough DNA damage in a cell, then the cell will usually destroy itself, so it doesn't create other cells with mutations, right? And so then that apoptosis leads to some dead tissue in that area, which that stimulates your immune system, gets inflamed, and that's why you get redness and pain and swelling with sunburn, because you have some inflammation there because some of those cells were actually destroyed. And then you get some vasodilation because of that injury as well, because of the inflammation, and that leads to some of the redness as well. Okay, and then tattoos. How many people got a tattoo? Everybody? Okay, we got a few. Yeah. This was another one students always asked about, so I did some research on it too. I don't have one. Yeah, do you? No, yeah, I don't have one. I always wanted one when I was in high school. Thought I'd get like one of those like tribal armbands or something, but I'm probably glad I didn't. My biceps aren't very big anymore, so I'd probably just be like all shriveled up now. So I'm glad I didn't get that tribal band after all. Yeah. So tattoos are kind of fascinating in a way. That needle has to get all the way through your epidermis. Okay, it's not just a little poke in there. It's got to go all the way through your epidermis, and the ink is actually deposited into the dermis, right? And so that pigment is injected down into the dermis. The pigment is actually engulfed by phagocytes, by macrophages mostly. Okay, so the macrophages recognize this as something that's not supposed to be there, so they engulf it. Okay, and then eventually, somehow, I don't know if we've quite been able to connect the dots. Somehow, these same pigments get incorporated into what the fibroblasts are making. Okay, and the fibroblasts are making that connective tissue, and they really just start sending out this extra pigment that came from the skin, and it all stays in that area. And so you really just have these kind of pigmented proteins now in the dermis of your skin because of that. So yeah, so it really just kind of becomes part of the connective tissue. Yeah, go ahead, Annalise. Yeah, there's definitely some over many years, it can definitely disperse. With the dermis, it doesn't turn over like the epidermis does, right? And so we don't have that same level of like new cells being there all the time. It definitely does turn over the years, and those proteins are replaced. So tattoos over many years do fade in some ways, and sometimes people need to get them kind of redone if they want them to be bright and stuff again. So yeah, it does, but it takes years and years to do that. It's not a super quick process like it would be if it was in the epidermis. Yeah, good question. Yeah. Okay, any other questions? Go ahead. Yeah, that's another great question. Yeah. Next year's class, I'll have slide 28 that says tattoo removal. And I'll look it up. Yeah, that's a good question. I'll look it up after class, see what I can find. Yeah, go ahead. When you get what? Oh, can it cause? Yeah, it can be connected to all types of skin cancer. Yeah, for sure. So it's a risk factor. Sunburn is a risk factor for all three of those types of skin cancer for sure. Yeah, yeah, good question. Yeah, Grace. Yeah, good question. Hold on a sec, guys. We're not quite done. Yeah, Grace asked, why do some people bruise easier than others? And there's definitely some genetic things to this with your quickness to clot and things like that. We'll get into that next semester with the clotting factors and the clotting cascade. Yeah, that's kind of the most I know about that. Is there's some level of kind of clotting timing, and that does vary based on individuals. And then it could definitely vary based on your age, and if you're on certain medications that might inhibit clotting, the clotting cascade. But yeah, that's kind of all I know on that. Yeah, go ahead. Birthmark, yeah, so that's just an area where we have a lot of extra pigments, okay? And for some reason, a lot of times those are genetically kind of programmed things where you just have extra melanocytes in that area, and they're just putting lots of extra pigment into the skin in that area. That's pretty much the best way to explain it. As far as, yeah, I don't know anything beyond that, but it's definitely the melanocytes adding extra pigment to that area. Yeah, Zoe? Like permanent discoloration or permanent? Yeah. I mean, it could just be, it could just take a long time to clear out the damage from that injury. The other thing that can happen sometimes with bruises is if we don't clear out the blood and the other things that were kind of sent into the interstitial space because of the injury, it can eventually kind of turn into harder and harder things. You can get something called osteomyositis ossificans, I think is what it's called, where that blood eventually turns into bone inside of your muscle. And it can become pretty debilitating. You can actually have like a little bone chunk, like right in the middle of your muscle. So if you keep kind of inflaming that same area, then the body just, it's like, all right, I'm just gonna make it harder and harder and harder. So to protect myself, and it can eventually turn it into bone. So yeah, so that would be an extreme version of that, but other versions it's just taking a long time to clear out all that debris from the injury. Yeah, great questions. Any other questions? Okay, oh, go ahead, Grace, yeah. Yeah. Yeah, it's a good question. I don't have a perfect answer to it. Part of it has to do with during the healing process, when we're laying down new collagen. There's different types of collagen that we lay down. There's kind of primary collagen and secondary collagen. And a lot of times that primary collagen is laid down in kind of just a very mismatched type of kind of like a mesh network. And then eventually that collagen will be replaced with the secondary collagen or type 2 collagen that becomes much more parallel and much more uniform. And so it can be a long process of going from the kind of early healing to the later healing. And so that's part of it. I think there's also can be, if there's some damage to those basal cells in the epithelial tissue, and sometimes they just don't come back exactly the same as they did before. And so they don't produce the exact same pattern of skin up above. Those would be my two guesses on that, but I don't know exactly, but yeah. Okay, so no hair questions, but we got lots of skin questions. Go ahead, Caitlin. Yeah. No, moles are the same idea. Lots and lots of melanin pigment from those melanocytes in that one specific area. Exactly why it happens in certain spots and not other spots, I don't know. There's definitely some genetics to it, but it is typically those melanocytes just putting a lot of pigment in that one specific area. Yeah, go ahead. Skin tag, yeah, I don't know the exact physiology of that. Yeah, I don't really know. That's a great question, but usually it's like kind of something that kind of like sticks out, right? Like almost like a wart, but not a wart. Yeah, I don't really know. Yeah, go ahead. Yeah, that's a good question. So Botox. Yeah, I mean, so Botox is really not going after your skin at all. Botox is it's what's called botulinum toxin, and it pretty much it's pretty crazy. It's the same thing you get from botulism. Like if you eat something that has botulism bacteria in it, it releases the botulinum toxin, and that botulinum toxin actually works its way up your neurons, travels through that same axonal transport that we showed that little video of those things walking up. Instead of them walking down to the end, they walk back up towards the body of the neuron, and then they pretty much can travel, that toxin can travel to adjacent neurons that are, their job is to cause that muscle to be inhibited a little bit and not contract as much. And so what happens is those inhibitory neurons actually stop working. And so you end up eventually kind of blocking those, and pretty much in the end making it so those muscles aren't contracting as much. And so it just relaxes some of those areas. And so that can help with wrinkles, but it really had nothing to do with the skin. It has all to do with the muscles that control the skin. Yeah. So, yeah. Go ahead, Annalise. Yeah, good question. I don't have a good answer for that one. Yeah, I don't know. Yeah, I'm not sure. Somebody writing all these questions down for me that I got to look up later? No? Okay. Yeah, go ahead, Trevor.
Why is it that skin gets darker with sun, but hair tends to get lighter?
Yeah, good question. Well, with the skin, it's literally a reaction of those melanocytes putting in more pigment in the next layers coming up. With the hair, it's already out there. The protein's already out there. And so that protein itself is just kind of being dyed. So we're not making new hair cells that fast, but with the skin, we're making new hair cells. And those melanocytes can actually put new pigment in, like right in response to that sun that was experienced. Yeah. Yeah, Annalise?
I could be wrong, but a while ago I was looking at section meters.
Hmm.
Pigment
Okay.
small enough that it can then disperse quicker. So I think it just breaks up pigment smaller.
Yeah, that makes sense. Cool. Thank you. Yeah. All right, guys. Well, we can still be done a little early. Have a good rest of your day. Great questions.
Actually,